So COVID-19 is the disease. SARS-CoV-2 is the virus that causes the disease. This is the same family of viruses that brought us SARS. So what do I do for a living? Basically, I look at warning signal patterns. Okay, so for those of you who recall the days of indication and warning analysis, that's the methodology that I practice. So I'm looking for indicators of unusual outbreaks, not typical public health stuff, but stuff that doesn't look right, okay? This is the actual 1918 signal pattern from Philadelphia, and it was extracted from their local media. And so we're one of the few teams in the world that have ever gone and dug through all the local media to look at pandemics from 1889, 1918, 1957, to really understand how did society back then come to realize that, oh my gosh, we're about to get hit by something. So we're specialists in looking at what is this ripple of pattern of awareness that we have a threat, okay? I want to highlight this. This is the east to west spread of recognition of death in 1918 due to the Spanish flu. And the reason why I'm showing you this figure, okay, so the blue lines there is the East Coast. The green lines are sort of middle of the country, Denver and Columbus. The red lines are on the West Coast. And what we're trying to show you is how fast and pervasive that went in 1918, to give you perspective, okay, that this is not the signal pattern that we've been documenting so far with COVID-19, okay? So when you see the media talking about 1918, they really have no idea what that really looked like. It was like somebody turned on a light switch and the entire country lit up with death, and a lot of death. We're talking 900 deaths per 100,000 population in Philadelphia. I mean, it's an unfathomable number when you do the math, okay? So when you see the media talking like that, the reality is we have no modern context of what that really would have meant in today's world, okay? This is what happened on January 1st. So we've been on deck since late December. And on January 1st, it is very, very, very rare for me to communicate directly with WHO. When I do, I'm doing it for a reason. And on January 1st, I told them that we're paying attention to a situation in Wuhan, China. You should too. We also told them that the signal pattern did not match SARS, meaning that they weren't talking about deaths. They weren't talking about panic evacuation. So one of two things was going on. Either A, this virus is not as lethal as SARS, and or they are reporting this at a part of the sequence that is way early, right, than what they did during SARS, okay? And as it turns out, both were true. As soon as things started going hot in Wuhan, we started matching the signal patterns against our signal libraries for 1918, 1968. The 1968 pandemic of influenza was considered the mildest of all the antigenic shift pandemics. And what we're trying to do is just approximate, okay, how fast is this going? How many cases per 100,000 population? I mean, are we able to approximate just how bad is this? Because you have the media hysteria going on, and then we needed to understand real perspective. Does this match up with the known numbers? So on the one hand, you had mathematical modelers who were trying to model what was going on, and they were making shrill claims in the media. What we were trying to do is say, okay, I acknowledge that you're a gifted mathematician. I'm not a mathematician, all right? I'm not going to challenge you on your math or your models. What I'm trying to do is to match your hypothesis to what we're actually documenting on the ground and compare it to our signal libraries, okay? So, sorry guys, this is a little touchy here. So this is what the epidemic has looked like in China. On the left there, these are cumulative case counts in the orange line, cumulative deaths in the gray line. The fatality rate, which is basically the deaths divided by the cases, you see that it fluctuates as revealed by the blue line. Now currently we're at 3.9% fatality reported at China. Now, how do you get to that number? Well, if you test everybody in China, that fatality rate is probably less than 5.5%, right? But if you only test patients that are being hospitalized, you're going to run that fatality rate up pretty high. And what's going on in China is they're sick and tired of testing, right? So what they're doing is they're using CT scans to diagnose patients. They're they're really backing off on the level of aggression that they initially executed for testing. So right here, so in the middle part of that graph there in February, early February, they're being very aggressive about testing, okay? And so the fatality rate dropped. Also, what we were noticing is that they were getting good at managing patients for a while, and then they experienced periodic time points where their healthcare providers got overwhelmed, and then the mortality rate would sneak up on them. So they've been fighting a war there, okay? Now, the good news is, on the right there, that's the epidemic curve over time. They have indeed reported less cases, less deaths. Now, we take that with a grain of salt. There's tremendous political pressure for them to get back online and get the supply chains back up and running so that we have PPE and medications, right? So there's all kinds of pressures placed on China right now to make this go away. So trust but verify, trust but verify. That's a constant theme throughout this entire 74-day process that we've been engaged with. So we've been on deck for 74 straight days without a rest. All right, so what is the disease? So the data out of China suggests that this is a disease that mainly affects older people in terms of severity, unfortunately, okay? And the mortality rate is pretty excessive when you get above the age of 80. So we're looking at about 15% mortality estimated from China.
Okay. Did everybody just take a deep breath?
Well, I mean, I'm 50, so I'm in the range. So, I mean, it's not like we're all in it. We're kind of all in it together. Okay, comorbidities. Hypertension is emerging as a kind of a key comorbidity. But this idea of, well, if you're older and have a lot of extra disease, that those are the only people at risk, that's not really true. So if you see here, the comorbidity level was up to 40%, so that's not 100%, right? So, you know, they are seeing, or they did see supposedly healthy folks still get ill and have serious disease. Symptoms, delightfully ambiguous. Okay, so I'm on the front. I mean, I need Ebola. I need blood spurting from eyeballs here. I mean, that would be good, right? Because then I can say, hey, that's COVID, right? The problem here is we're talking fever and cough. If I told you how many kids I see every time I walk in the clinic with fever and cough, I mean, you know, come on. There's no way to distinguish is the problem, okay? The interventions. From the Chinese, they were seeing a 5% ICU admission rate. So that's the intensive care unit. For mechanical ventilation, 2% of those patients were requiring ventilation. They did try ECMO. They abandoned ECMO pretty quickly. ECMO is pulmonary bypass, right? So you take them off the vent and you're using a machine to oxygenate their blood. They gave up on that pretty quick. They didn't have enough capacity. So 80% estimated of the infections are mild. I think that number is a lot bigger, to be honest, that percentage. The incubation period, about 2 to 7 days, is spread by respiratory droplets, so 6-foot radius. Very similar to a virus that we deal with in pediatrics called RSV. So we have other routine viruses that exhibit very similar transmission characteristics. There are no known vaccines or antivirals. There's a whole bunch of stuff in trials. Every time we have a health security crisis, you've got tons of people coming out saying, well, we got a vaccine, it's going to be available. Don't believe them. I mean, it's a money play, okay? They need money to develop the vaccines, but the reality is a lot of this stuff is not ready for prime time, hasn't been FDA test, you know. There's a whole lot of trials to determine safety, right? I mean, so got to take it with a grain of salt, all right? Quarantine isolation is 14 days, so that's 2 times the incubation period. That's why that number's there. This is a little difficult to see, and I'll try to walk you through this figure. This is the progression of illness as reported by the Chinese, and I'll give you some caveats here. So day 0 is your illness onset, so you've incubated for a few days, and now you're showing symptoms, right? The Chinese felt like it took about a day before you saw fever. There are other studies showing that folks can go for many days without showing fever if they show fever. The Chinese were estimating 94% of the patients showing fever. At day 4, that's where the virus is shedding and the respiratory secretions at maximum. So you're able to transmit, right, to others maximally at day 4. If you're going to get into trouble with this disease, right, that's about day 7. Hospital admission on day 11. If you need to go to the ICU, it's the next day, so things go really quickly from there, right, in terms of severity. And then the cessation of virus shedding, meaning that you're not going to transmit to others, is believed to be about day 20. So very long period of risk here is kind of what we're highlighting. And then death is typically by day 21. For those majority of folks who have the mild illness, right, recovery is by day 32. So it's kind of a long process, you know. All right, fatality rates. So 115 territories and countries are reporting cases right now. If you test for this virus, you'll find it. If you don't test for it, it doesn't exist. You're going to see that there are a multitude of countries that probably have cases, but you're not reading about them. Vietnam is one, Thailand's another. Oh, no, Russia doesn't have any cases. No. Right now, Italy leads the world in terms of fatality rate. Okay, they are really getting up there. What's going on there is they were not prepared. They got caught by surprise. It hit the worst possible place in Europe it could have hit, a population with a high percentage of elderly folks. Okay, so that's awful, right? That's kind of what happened up in Kirkland, Washington, right? So these are folks that are at high risk of severity and severe outcomes, okay? So they also don't have the lab capacity to test everyone in the community as well. So you're seeing a convergence of a lot of factors that are producing that feeling of, oh my gosh, this is really lethal. Well, they got caught out, okay? They didn't prepare. That should be a warning for us in this country if we choose to listen, okay? Iran was next. Iran's fatality actually got as high as 16%. But again, that's because they didn't test. And what they were reacting to were people dying. Then they engaged and started testing more, and then you watch the fatality rate drop multiple percentages every single day. United States is in there. We were the leading country in the world for a couple days there. But then we got our testing up and running last week, and now we're dropping you see the pattern, okay? So don't be reacting to media reports of absolute death counts is the point here, right? The more you test, the more you're going to have a bigger denominator and drive those fatality rates down, okay? South Korea, we think, is a more accurate representation of what's really going on. They've been hovering around 0.5 to 0.7% mortality. South Korea is doing a ton of community testing. Okay, perspective. One of the things we like to do to give us perspective is to divide the number of folks who have been diagnosed, those would be the cases, or the folks that have died, divide it by the population. So you want to control for population. So if you have, say, 1,000 people die in Hubei province in China, you think, oh my gosh, that's 1,000 people. The planet is doomed. Well, how many people live in Hubei province? 59 million people. Let's get our head around that. 59 million people, okay? And if you look at the mortality of influenza, and this is why we use the influenza comparison, and some folks will violently debate me on this. I like using influenza as a comparison because it tells us, listen, we can handle that kind of an infrastructure demand. That disease is believed to produce, so far this season, we're not even done with the season yet, we're about halfway through, 11 deaths per 100K population in this country, compared to 5 in Hubei province, compared to 6 in Lombardia, Italy. So we want to understand comparisons here, right? So right now, at a country level, Italy is leading, okay, at 1.4 roughly deaths per 100K population. We're going to talk about what it means to have that all happen in a short period of time, too, because that's the other thing, is how distributed is that number. The U.S., we got to keep this in mind, what is actually reported on our death certificates in this country is about 1 person per 100K population per week die of pneumonia and influenza. So some of what's going on here, too, is if we got a boogeyman that just showed up and is killing people, we're going to pay attention to the boogeyman and we're going to ignore the threat that we know well. Now, I really want to emphasize this. Those statistics for influenza are despite the fact that 50% of the population vaccinates and despite the fact we've got Tamiflu. Deaths. So Daegu, South Korea, they're at 1.7 deaths per 100K population. We keep these stats updated on a daily basis, so this is obviously a very fluid situation. Hubei province hit 5 deaths. Lombardia has now hit 6 deaths. We're estimating 11 deaths so far, halfway through our seasonal influenza season. 1957 influenza pandemic in the Netherlands was estimated to cause 27 deaths per 100K population. The Netherlands, 1889, 100 fatalities per 100K. 1918, 896 fatalities per 100K population, Philadelphia. So when I say that we really don't get it in terms of what a real pandemic would do, this is kind of what I mean here, okay? Now, keep in mind that an influenza pandemic, the bulk of that mortality from an urban city perspective will occur within about, 4 to 6 weeks. So these bell-shaped curves are really tight with influenza, okay? So it does happen fast, and it's extremely explosive across multiple age groups, okay? So it is useful to kind of keep a little bit of perspective here. Is this the same disease? Nope, it's not, right? Because if you are infected, your chances of dying are indeed quite a bit high compared to flu. But that doesn't mean that your risk is the same. All right, so let's talk about flu. We test for flu at a rate now in this country that is historically unprecedented. A lot of testing for flu, okay? So what we're realizing now is part of the dynamic going on here is with access to diagnostic technology and our ability to test for things, we're becoming more aware of, hey, we really do have a lot of death and morbidity due to flu. Does that mean flu is necessarily any different than what we've seen in decades past? No, it's just we're now recognizing the true burden, okay? It's one way to look at it. So right now, CDC is estimating 12,683 flu infections per 100K population. That's mind-blowing to get your head around, okay? This is despite vaccination, despite Tamiflu, okay? Nearly 150 inpatient admissions per 100K population, 11 deaths. So that's a significant burden to our healthcare system. So it's important to highlight this is what we are managing at routine baseline in our healthcare system. Okay? Now the mortality, 0.1% among all the infected. But if you look at the mortality of how many folks were in the hospital who died, the mortality sneaks up to 7.4%. So this is a deadly disease that we just deal with routinely here, okay? All right. Now, the acute care capacity. So I put the influenza stats up there at top. We have 165 estimated beds per 100,000 population, 29 ICU beds per 100,000 population. So with this infrastructure, we are able to manage flu, okay? This is the situation in Hong Kong. For some perspective, they're seeing 1.96 inpatient admissions right now. So this blue line is basically their daily inpatient admission status in Hong Kong. So Hong Kong, they saw an initial peak. They probably adjusted their admission criteria and kind of learned how to manage the patient flow a little bit better, and they brought it down. And they're hovering around right now about 136 patients a day that are maintained in-house, okay? So they're able to stay on top of this. Their average wait time in the emergency department is between 1 and 3 hours right now, as of this morning. Singapore. Singapore rocked it initially. They're getting a little bit of trouble now. That blue line indicates that they are starting to see a lot more people get admitted. Their ICU admission rate currently is at 10% of those hospital admissions. So we're watching Singapore very closely because they have been the best in the world to manage this situation. They managed to keep their city open. They do have isolations. They do have quarantines going on, but they're able to keep their business going. But their ICU percentage, if that starts sneaking up much higher, they're going to risk collapse of their ICU grid, and that's kind of what we're watching for here. So 3.3 inpatient admissions per 100K, 0.5 ICU admissions per 100K. Japan, 6% of the hospitalized cases are being admitted to the ICU. Their fatality rate overall is 2%. They too have a high high percentage of elderly citizens in their population. So we're seeing differences from country to country here, some of which are easily explained, some of which not as easily explained. The number of deaths per 100K population is 0.01 compared to our 11 deaths per 100K for seasonal flu. South Korea, 15 cases compared to 12,683 cases of flu / 150 admissions per 100K population, right, for flu. 0.13 deaths per 100K. Their deaths, so one of the things we were doing here is everybody's like, oh, you can't trust China. You can't trust their data. I'm like, okay, yeah, well, I've been doing this for 25 years. I know that. It's trust but verify. The verify was the second level of the next countries that were affected by this virus. We pounced on their data pretty quickly to see if there was a data match. Is what China was seeing in Hubei province, is that what the South Koreans are seeing? Is that what the Singaporeans are seeing? Like, are we seeing some degree of agreement here? So this is an example of that, right? Where the South Koreans as well are seeing much higher fatality amongst the elderly patients, okay? So basically their data looks a lot like what the Chinese initially reported in January. This is the hot zone in South Korea. This is Daegu. So, Ty, I wish I could have given you a complete doomsday lecture, but I can't. This is indication that the South Koreans are getting control. So we got South Korea staying on top of things. We got Singapore more or less staying on top of things. We got Hong Kong staying on top of things. So we do have countries showing us that it can be done, right? It's a mess. It's stressful. There's strain. There are a lot of people dying, but yet they're still kind of staying on top of it, all right? Here, though, this is interesting. When you go down to these really intense pockets of localized transmission, you do see the incidence sneaking up on you here. So 252 cases, or approximately 50 admissions per 100K population, happening in a relatively short period of time. So this graph is approximately over 30 days, okay? So kind of like an intense flu season, right? On top of their pre-existing flu demand. That's the catch, right? That's really what the real issue here is the world is already dealing with flu season. We don't need any added problems, okay? 1.72 deaths per 100K population, okay? All right, Lombardia. 38 inpatient admissions per 100K population. That's accurate as of this morning. 5.6 ICU admissions per 100K, 6 deaths per 100K. So they're starting to get up there. This locality is starting to sneak up close to what we see for seasonal flu. So we're watching this area of the world pretty closely. It is the hottest area of transmission in Europe. You can look at it this way. From a local perspective, Daegu, South Korea, Hubei province, China, Lombardia, Italy, from their local perspective, it is a full-scale disaster. They are in full-on wartime emergency response. They are making triage of ICU admissions. If you don't look like you're young enough and have few enough comorbidities, they're not going to put you on a vent. Okay? So they're making really ugly choices there about who lives and who dies. From Italy as a nation perspective, yes, it's an emergency, it's a crisis, but the entire country doesn't look like this. It's a locality. Now, the pattern we're seeing right now, and we only have a sample size of three countries, is you'll see one locality go down, and then all the other provinces in that country say, holy cow, what just happened here? We better prepare. And then they prepare. And then the other provinces do much better. But that one poor province that took the hit for the rest of the country goes down in flames. Is that going to happen in Seattle? We don't know. Is that going to happen in New York City? Don't know. I hope not. But that's the pattern that we're seeing so far. So here's a reminder. We're about halfway through the flu season. And we've managed to handle this, right? But this is routine disease. The hope here is that if we can get through this season and it starts to taper off and free up some of these ICU beds, then we'll have a little bit more capacity to handle whatever surge we're about to see, but no one really knows. We have reporting right now out of Northern California in the community level. This is not in the main cities, of influenza A, influenza B, RSV negative, severe respiratory illness. So these are emergency physicians reporting into us. So we have a pretty robust network up and down the West Coast, and we're watching everything like a hawk right now. And what we're looking for is people talking about unusual disease. But here's the catch. Everyone is anxious. They're looking at any kind of report of fever, cough that, oh, that's automatically COVID, right? The reality here is down here, this is the actual respiratory pathogen profile for our nation. And right now, we have a lot of rhinovirus, we have a lot of metapneumovirus, we have routine coronavirus, adenovirus. We got other viruses that we deal with routinely that are showing up and presenting with similar symptoms. So there's confusion. So here's the dichotomy. We've had people get on our media and say, well, we're headed towards the Spanish influenza. But at the same time, they didn't give us laboratory test capacity to be able to resolve uncertainty. So you have basically scared the living heck out of everybody, including our frontline responders, and not given us a means to resolve uncertainty. That's terrible, right? We're in a terrible situation. So lots of anxiety right now among our physicians. Understandable, because they see themselves as being at risk. The caveat here is what the Chinese saw is about 5% of their healthcare workforce got infected. And they didn't see that many fatalities. There were the 1 or 2 physicians that showed up on the media. But if you look at the 40,000 healthcare workers that were mobilized into Hubei province, 5%. We're seeing similar stats out of Japan and South Korea. So obviously a fluid situation. The point here is we don't really know what's going on, okay? So the goals of community mitigation. So this is why you're seeing healthcare system here trying to push everyone away, including me. If you got a sniffle, if you got a little fever, if you're not critically ill, please recover at home. Don't show up to work. Stay at home. Because we don't want tons and tons of disease coming into the emergency room, overwhelming the emergency room with the anxious well. You also want to slow down the contact rate of people. So if you are sick, stay at home and don't come into contact with tons of people. Because if we can kind of slow down the peak and intensity of transmission, then you allow your healthcare system to stay up to the demand, if that makes sense. So I'll end with this. One of our elite team members is Karen, and she has lavender essential oils. And Karen is going to go to town on Corona. But all kidding aside, this slide actually says a bit more, a lot more, in fact. The number one thing our team is dealing with right now is hysteria that is amplified by social media. So if you're on Facebook and you're forwarding random media articles that basically say we're all going to die, then you're not helping. Because our emergency physicians are also on Facebook, and they get forwarded that stuff too. You don't want your ICU physicians or your hospitalists or your emergency physicians getting jacked around with their emotions and frightened to death because we cannot control this finger clicking our mouse. So I'm sorry for ending this on a tense note, but this really is a big deal. This business of, can we maintain balanced perspective? Can we have a balanced conversation? Yes, this is scary. Yes, it's a crisis. But we also kind of have to keep calm and carry on kind of demeanor so that we can focus on good, sound response and protect our communities. Okay? And that's it.
Jim doesn't sit still very well, so we're going to let him stand and answer questions. With that, and I assure you, Jim is on the front lines in a lot of different ways. He's also a practicing pediatrician, so he has seen way too much flu in this community this year among children, and two? You lost two patients? Two patients,
Well, the
two
community
young.
did. The community
Yeah,
did.
the community did. So he is putting this in perspective for everybody who's concerned. Okay, so Jim, you got a lot of questions. So let's get started. Let's start with some basics on the virus itself. Lots of confusion, and you brought this on with the media stuff. How does the virus itself kill people or affect people? What's the impact? What does it do to the body?
It gets into your respiratory tree. It starts off infecting the cell layers up here, in your sinuses and your upper airway, and it's believed to march its way down into your lungs and cause a lot of lung damage and edema and prevent your body's ability to oxygenate properly. So it's pneumonia, right? But the good news is that happens in a minority of patients.
Okay. So let's talk.
And by the way, that's very similar to flu. It's very similar to metapneumovirus, a lot of other routine viruses that we deal with.
So one of the things that you kind of went by quickly when you talked about the flu is that we do have a vaccine for the flu. We do have an antiviral. We have Tamiflu.
Yeah.
What do we have available in terms and you did mention that the vaccines will likely not be available for, they typically say 18 months. What's the progress?
Don't hold your breath.
Don't hold your breath. Okay, so 18 months, but don't hold your breath. Are there antivirals available? And if not, how long will they take?
Well, Gilead's got a product that may show some promise. It's compassionate use only protocol.
Explain what that is.
That means
and talk louder.
Basically, this means that you've got a drug that may be effective. We don't really know. It needs to be tested, and we're testing it on the fly. So what I usually tell people is, look, there's this flurry of activity of investigation around vaccines and antivirals or antibiotics. That happens with every single health security crisis, right? It happened during Ebola in West Africa. I mean, if you're counting on that to save our bacon and to justify you not being prepared as a healthcare system, I don't know what to tell you. Just don't do that, okay? So these medications, these drugs, these vaccines, they need to be tested for safety, right? We need to make sure that these medications aren't going to harm you in of themselves, right? So there's a whole process that needs to happen here. So, the bigger thing that we should do here is focus on what CDC is telling us to do, which is wash your hands. If you're sick, stay home, the basic stuff like that, okay? Unfortunately, I wish I had a magic pill for you, but, even with Ebola, even when we had a vaccine for Ebola in the DRC, only just recently are we talking about this epidemic coming to a close after how long? So I've been working that issue too. So just because you got a vaccine doesn't mean it all goes away. The pain goes all away, right? We still need to prepare.
So let's talk a little bit about testing. Could you give us a little bit more insight as to how the testing is going here? And if somebody comes into a clinic, are they automatically tested for COVID? Are they tested for the flu and rule that out first and then test for COVID? How is the testing going, and how's the availability of testing? Because we've heard a lot in the media about that.
Well, just so I don't cuss here in public.
Talk louder.
Very frustrating. It's been a frustrating situation. So the testing process was goofed up in the beginning. The access to testing is ramped up. Current turnaround times are between 3 to 5 days. If you go through the commercial vendors, we're seeing price tags as high as $190. Not everybody can be tested. We have seen states using sort of a triage protocol for testing. So the priority here really should be, in my opinion, to protect our acute care infrastructure. So we need to be testing patients that are about to be admitted, testing healthcare staff, right? There are questions, though, about do we even have the capacity to do that, right? So just having drive-throughs, yeah, they're talking about doing that. That's what they've done in South Korea. But we've had this huge delay in access to testing that, like I mentioned before, hasn't really helped, right? Because we've told people we're about to get hit with 1918, and yet we're not able to resolve uncertainty. So it's a terrible conundrum. So we're hoping things will improve, but what will happen with an increase in testing, and this is what is happening now, is you see more cases. Now, don't be misled. That doesn't mean that things are transmitting vertically. What it means is, well, we're recognizing cases that are probably already there, and we didn't know they were there because we weren't testing before, right? So we're kind of playing a lot of catch up here.
Okay, I'm gonna obviously I've got a lot of questions here, so we're gonna move through these quickly. Okay, so is there an obvious indicator? You're in the clinic, you see somebody walk through the door. Is there anything obvious to you that you're looking at COVID and not the flu?
Well, now I'm going to freak the audience out. So I've been on deck for 3 10-hour shifts back to back at my clinic, which is kind of why I'm a little ragged right now. And I've seen one family after another come in with fever, cough, fever, cough, fever, cough, fever, cough. Okay? There's no way for us to distinguish it. You know, it's hard to turn away a family that says that their baby is sick and they're scared, right? So triage for us, there really isn't much triage. And we are on the front line. We are probably getting exposed. Have we been seeing coronavirus in the community? We don't know. We have been testing them for flu, have been testing them for RSV. We have seen a couple RSVs. We've seen a couple flus, but the majority are RSV flu negative. Does that mean it's COVID? Well, I go back to this. So 16% of the isolates, respiratory isolates coming out of the ICUs in this country right now are rhinovirus. So that's the virus that causes the common cold, okay? So the bottom line is it's probably routine virus, routine respiratory disease, right? But we don't really know. And that's part of what's driving some of the angst among the emergency physicians is we're not able to provide context and tell if this is just baseline disease and we're just having a nasty spring combined with everybody's hyper and they're like hyper vigilant looking for this stuff, or if we really are seeing coronavirus. We don't really know to what extent we're seeing that.
Okay, so let's talk about some other stories that are out there. One is that the coronavirus will die down with warmer temperatures. Another is that it may become seasonal like the flu. Now, granted, if the epidemiologist was here, he'd probably have one answer, but I will bounce those to you.
Well, bottom line is we don't know. And where I sit in the spectrum of risk communication is I hate hyperbole. I hate hysteria. It drives me nuts because I see what happens to our responders if we go too far with talking about uncertainty. It doesn't help. Okay, and if we don't know something, maybe we ought to just kind of cool it and not hypothesize in the media because we don't really know what's going to happen. I will say this, though. This might give us a hint. The orange, you see that light orange there? See how it goes up and down on the graph here? Well, it goes down in the summer. That's coronavirus. That's the baseline coronavirus disease that we see in this country, okay? Now, by the way, we didn't even know coronaviruses were even in circulation in this country until after SARS, and we activated this kind of surveillance in the first place. So it's kind of like we're unpacking what was always there. So it does seem to slow down in the summer. So what's going on in the summer is higher temperatures, higher UV exposure because, sunny days. People are outside. They're not mixing indoors as much, right? So lower person-to-person contact rates. So I think what'll happen in the summer is we'll be given a respite, but we better have containment by then. Because if we don't, it might pick up again in the fall, and then, well, geez, we got to deal with another round of this, okay? So we don't want to be complacent. Am I hopeful that it'll die down in the summer? Sure. Yeah, I am. That is what happened with SARS, but, we don't really know what happened with SARS. We didn't test people anywhere near to the extent during SARS that we're testing now. So we are seeing a lot of cases with COVID, but it's difficult to compare it to SARS because we have so much more access, as a global system than what we did with SARS, right? We didn't do as much testing. So that's kind of where I sit with it, but you'll see that that light orange graph there does not drop to 0 during the summer.
Okay, so let's move from your medical hat back to your data hat. We're seeing countries that are not reporting. We're seeing countries that are estimated to be vastly underreporting. So
If you don't report it, it doesn't exist.
It doesn't exist, exactly.
If
So
you don't test for it, you don't report it. You don't report it doesn't exist. You don't take an economic hit. You don't take a political hit.
Right.
See, there are reasons for that, right?
So based from your data perspective, what could you say is likely to be the situation in places that we in the National Security Forum happen to be particularly interested in? Say North Korea, we already got Iran situation.
Swimming in it probably now.
Russia.
Yeah.
And then in the African countries, which seem to have only reported, sort of until recently, fairly low number of cases. So give us a perspective for those areas that we're not hearing huge amount of cases. What do you think is happening there?
Well, they probably have cases. We don't know to what extent. We would imagine that as they continue to see cases in their community, they'll probably see incidents, case and fatality incidents similar to what we've seen in other countries. It's just they're not reporting it, they're not testing it, and a lot of these countries are electing to simply take the hit, right? And so we have had eyes on the ground in a number of these countries, and what those eyes have told us, direct human observation, trusted source on the ground, have talked to morticians, have gone into the hospitals of these countries. We know, we have a pretty good idea of what they're seeing, and yeah, they are seeing a little pop of mortality. In Thailand, we were told in the middle of Bangkok that they're seeing a 20% increase in mortality, but they don't know what's causing mortality because they're not testing. So there are actually interesting ways of managing crises like this, right? So the calculus is rather fascinating. We have been in debate for a while as to if this whole thing had happened back in the 80s, when China didn't care one hoot about any of the surveillance stuff for disease, would we even have noticed it? It's a debate, right? And so that it does raise interesting questions about our perception of risk and the dependency we have on technology to define risk. Again, if you don't test for it, does it exist? So the interesting thing will be is to watch these countries who aren't reporting to see if you're able to discern if they really are taking a massive hit to their infrastructure, even though they're not reporting, not testing. Are you able to discern that through indirect methods?
Excellent. Okay, so let's do one more question on the disease before I get to a lot of questions on the response.
Okay.
So what are we looking for in the United States? What should we be prepared for here? From what you understand and for what you discussed about the progression of the disease, where are we in the curve of the number of cases? How prepared is our medical infrastructure to handle that? I think one of the really important points that Jim made was that you're laying the response on top of an ongoing flu season. So, this is happening while we're already dealing with the flu. So what's the make or break points for the medical system in the United States? And this following question to that is the medical community getting the resources they need in order to up the response in order to handle additional cases? So what are we looking for? Are we prepared? And are you getting the resources?
Well, the short answer is we're not prepared. The long answer is we don't have enough testing capacity yet to protect our healthcare system, in my opinion. We are seeing PPE shortages. So this is personal protective equipment.
Thank you.
This is like the masks that we're supposed to be wearing, the gowns, all the protective gear to protect healthcare staff from getting infected. We don't have enough of that. Some of that has to do with the China supply chain, which we hope is going to get better by the end of April. That's a ways away, right? So we're kind of in a bit of a mess. On the other hand, as I mentioned before, we are monitoring reports of unusual patient surge. So that's really what we're looking for. It's a late indicator, unfortunately. Ideally, we would have enough access to testing that we could just test out in the community and I'd be picking it up at the outpatient clinic level. But really, where we're trying to pick the monitoring points that we think we can actually make sense of. And so what we're looking for is report of unusual emergency department surge, and most importantly, unusual intensive care unit demand, right? So patients coming in and filling up ventilator beds. The problem with that indicator is that's a late indicator. If you're waiting for that to respond, you're already in it, and you're going to have what happened with Lombardia, right? So this is the challenge here: is how do we detect what's going on and have enough certainty with that detection point to know and be able to quantify what's happening. That's the challenge. And so I will say this, though, that Seattle, some of their local experts got on Twitter, of course, and said, oh, well, we have this pocket of mortality in this nursing home, therefore it's been transmitting cryptically in the community for the last 6 weeks. Well, if you look at what happened at week 6 in Hubei province in Wuhan, by then they had seen tens of thousands of cases and multiple thousands of fatalities by then, and a totally overwhelmed healthcare system. So there's a mismatch between, again, what people are fearing and they're speculating versus the ground truth of, well, okay, if we believe that, then roughly at this point, there should have been no question that that healthcare system is getting slammed. And it isn't yet. Now, the hospital that managed the cases from that nursing home, yeah, they're pretty stressed, right? No doubt about it. But that's different than saying that the entire medical infrastructure grid of Seattle is now inundated. That's not what has been reported. Okay, is that a potential for the future? Sure it is, right? And that's what we're looking for, and we're worried about that. I think my point of nervousness, though, is you got to walk this fine line. You know, you don't want to be Chicken Little, but you don't want to be accused of knowing something and not telling us, right? How do we get people to prepare appropriately? How do we do that, right? In a way that makes sense, in a way that everybody's going to be happy. That may be asking a lot, I think. Did I answer all of those questions?
Yeah.
Okay.
Are you resourced appropriately?
No.
Could you
No.
be a little more specific?
We're not expecting any funding from the government for the next 30 days.
Which
So,
means you are operating how?
our team's been, I mean, I'll be blunt, our team's been operating for 74 straight days to protect this country without one dime of funding. Not one dime of funding. We've taken it out of hide. I've sent people into these countries with no funding. They put their lives at risk. They were at risk of getting arrested. They were at risk of getting infected. I'm working with our NATO allies right now, giving them medical intelligence guidance on what kinds of things they need to be looking at. Our government does not support a bit of it. So these reports of our leadership not trusting certain elements of our government, well, some of us have decided, you know what? We still need to protect this country, and we're going to do it. So that's a choice, right?
Okay. Oh, on that happy note,
Don't know what to say.
we're going to move to response. And obviously, there's probably a lot of questions about response, but I'm going to start with the most obvious one. Is the sky falling, or was that just my 401k?
Take the Dow Jones Industrial Average on Yahoo Finance. Do not look at the current window. Click max first. That's what you need to look at first. Look at the max value, right? So that it kicks it out to multiple decades of what the Dow has done. That's the first thing you need to do. And you'll see that the Dow has jumped all over the place during these kinds of health security crises, and it has recovered. Okay? Now, it took a while to recover. So, true story. In 2009, our team had provided the warning on swine flu, right, to CDC. Okay? Our company died because the bubble had burst. So, true story, I was standing in London in a tailored British suit talking to a member of Lloyd's of London, advocating for an enterprise-level subscription to the insurance industry for our intelligence services. And the fella comes in the room, the lead of their analytic team comes in the room, and he's got sweat stains about this big on his shirt. He's not wearing a jacket. He ain't happy. He doesn't look like he slept. He said, listen, fellas, this looks fantastic, but I got to tell you, I just had to fire off half my analytic team, and I don't even know if I got a job next week. So that was the end of our team then. So it's kind of interesting. These things come in cycles. There isn't much sustainability to these processes. We find ourselves constantly reacting with the next crisis. We're not maintaining corporate memory. The Dow Jones goes all over the place. I will admit, this was a doozy this time. The question I would ask anybody who's paying attention to the market is this due to the direct effect of the virus infecting people at scale to cause enough worker absenteeism to do this, or is it anxiety? And really, anxiety that's amplified by social media. So the national security question here, yet again, is do we really want social media in our society?
Okay, that's a whole different topic for which I will not have an MD for. Okay, so given that we are where we are things like banning all travel from Europe or some amount of travel from Europe, closing schools, closing businesses, telling people to self-quarantine, is that going to have a positive effect on slowing down the spread of the virus? I.e., are we going to be able to level the curve?
Well,
Any of those. Take them.
So let's get a show of hands. How many people in this room think that we could be like Singapore and follow official orders to self-isolate and quarantine and do what every citizen should do? How many hands believe that we can do that in America? Oh my gosh, I have not a single hand raised. So here's the irony, is authoritarian regimes actually do much better with these kinds of crises than democracies. So actually, I mean, we can talk about isolation all we want. We can talk about quarantine all we want. The question is our citizenry going to be on board with that? And my, I guess, sardonic answer is no. Not by a long shot. I mean, I'm still looking for toilet paper. My wife's tired of me using our laundry for that.
So there was the ban on travel to Europe. So in case people didn't
That's not going to make much of a difference at this juncture, right. I think we've already been seeded.
So just so in case you hadn't noticed last night, right after the president's speech, the State Department issued a level 3 travel advisory, which is global. So level 3 means please reconsider all travel. It doesn't say don't travel, but it says don't travel, reconsider any travel to anywhere in the world. So it's not just Europe. The level 3 advisory is global. So for anybody who has travel plans in the future, remember there's one thing about going somewhere. There's the other thing about you want to come home at some point. So keep that in mind. Okay, so one of the targets that we've had, and maybe you can explain why it's been such a big issue and how we should look at this, is the cruise ship problem. Now, as we know, cruise ships have been floating petri dishes for other things in the past, like norovirus.
That's my favorite one, is noro. I love noro.
So what exactly should what's happening? Why are we seeing so many cases on the cruise ships? What can the cruise ship industry do to address this problem for those who might want to take a cruise, say, next year at this time?
Well, I don't know what to say to the cruise industry, except I'm so sorry. And I hope you've got a good insurance policy. The cruise ships, the problem with cruise ships is you're in a contained environment. So it's going to sound really bad, but when the Diamond Princess was quarantined, we basically sat back and we watched that very carefully because that was one of those secondary validation monitoring points that we were looking for to validate what was going on in China. And what we were looking at is how many people are going to die because they kept them in a contained space. We knew they weren't going to manage it completely 100% perfectly. We figured that people were going to get infected. If it was aerosolized, then half that ship should have gone, right? But it wasn't. right? So what we were looking at was, okay, it's on like Donkey Kong on that ship. Not my idea of a good vacation. Well, actually, my idea of a good vacation is to go on a ship and have an epidemic. That would be fun for me.
Don't plan your
I will
travel
say,
with Jim,
I need to
please.
confess something. I said that this town needs a good epidemic. Why? Because I'm sick and tired of dealing with folks who refuse to vaccinate. So I was like, finally, people who actually appreciate that. You're the first people who've ever actually clapped at that. Usually they try to lynch me out in the parking lot. But yeah, this town needs a good epidemic. And now in the pod yesterday, I said, can I take that back now? That was just a joke. The good Lord said, oh, no, funny man, we're gonna play this out. But coming back to the cruise ship, that's a contained airspace, right? That's like if you're going to test the real stats, unfortunately that's a place to do it. Now, what was the fatality rate on that cruise ship? All things said and done, anybody know? Well, when you look at it in terms of per 100K population, it's like 0.7, right? So it's down around South Korea. So we kind of use that and say, okay, that's just one sample, right? And it's not a perfect test, but it helped reassure us at the time, okay, it's not 2.5%, right? Which is what Hubei province was reporting at that time point, right? So, cruise ships, I don't recommend anybody go on a cruise right now. That'd be a party foul. Don't do it. And because one of two things is going to happen. Either A, you're going to have a little outbreak and you're going to get stuck offshore from somewhere, and then you're looking wild-eyed at your cabin mate and the folks down the hall, and then you're going to fight over food, and it's just going to get ugly. So just don't.
Okay. So everybody stay home, please. And I do understand we're welcoming back 40 plus passengers from Nevadans. Okay, they're fellow Nevadans. They're fellow Nevadans. Remember that.
I was hoping you weren't going to mention that, but
yeah. I'm not sure where they're going to be quarantined. You don't have to tell us, but they are coming back. So, probably not a great time to be planning a cruise. So, when you look out, and I'm going to let you have the final 2 minutes, Jim, here.
Well, wait, if I could just say one other thing, just to be clear, right? Your per person risk on these cruises, air flights, if you decide to travel, it's not so much you getting infected and being severely ill. It's more, what are the people doing around that situation, right? Are you going to get stuck in quarantine? You're going to get stuck in a travel restriction? Mm-hmm. Are you going to be able to come home? Okay, so just kind of keep that in mind. It's right now, anyway, that's your higher risk. Definitely don't go to Lombardia, Italy.
Well, you can't.
Don't try. I mean,
don't even try.
Yeah,
So in the final 2 minutes, Jim, I want you to close with what this community is looking forward. Okay, so we have heard people, and the guidance that if you didn't get a copy, I think there's still some copies back here. That's CDC guidance for what you should be doing. That's the social distancing, wash your hands, all those things. One thing I have seen is signs in the hospitals that if you have a respiratory issue or a fever, and you're coming up to the emergency room, typically they have you stand back and call in case so that they can treat you appropriately and you don't walk in and infect the institutions. What are we looking at? Okay, so we are now at March 12th. Give us your best idea of what Reno, the country, is going to be going through in the next, say, 8 weeks, and how do we as individuals and we as part of a community that cares deeply about each other do to prepare ourselves, our community, take care of loved ones, and not be a risk to anybody else. So give us the positive note, but tell us also realistically, what are we looking at?
Well, I mean, just know that some of us in the community are working really, really, really hard to maintain perspective, gather information. We're trying to connect the intelligence that we're gathering in these countries directly to healthcare preparedness. We're doing the best we can. So there are a lot of folks working hard, despite some of the hiccups with our leadership in the country. I don't want to get into politics. It's just we have to accept the situation we got. We're going to war with the army we have, not the army we wish we had, right? So I'm hoping that this turns out to be similar to some of the other countries where we might see one or two nasty hot spots in the country, but they're not Reno, right? Like New York City or unfortunately maybe Seattle. And then the rest of the country gets its act together after they see what happens in those cities, and then the rest of us are able to see more resilience and preparedness and response, that kind of thing. For you as an individual, it's interesting. We've had a really hard time, our team has had a really hard time communicating with the public because folks fall seemingly into one of two categories. Either A, you roll with it and you've accepted the fact that you can't control uncertainty, or you don't. And the folks that don't, they're the ones that we have to ban them from social media. We have to cut them off. They don't get access to our reports. I mean, seriously, it's a bad problem. It's not, and I feel bad for these folks, right? I mean, because they're suffering, okay? So I guess my counsel to everybody is wash your hands, don't touch your face, right? If you are sick, don't go to work, right? Let your employer know. Try not to shake hands, which is kind of hard. I mean, I gave Maureen a hug, so do the things that we're supposed to do anyway during cold and flu season. Listen to your officials. Do not demand access to testing. Okay? You need to think about the broader community. We need the testing reserved for the folks that really need to be tested in our infrastructure, to protect our infrastructure. Stay off of social media. I'm actually serious. Like, really, stay off social media. You don't need to be reading the newspaper. If you want to look at something, go straight to CDC's website, go straight to Washoe County's website. The social media is going to make it worse. The more you look at it, the more scared you're going to feel, and I think it's unnecessary. All right? Going to your doctor, don't pressure your healthcare provider to be seen if you've got a runny nose and fever. And I know that's hard to do. I mean, some folks do have chronic illness and they kind of need to be seen, but just, don't fight the triage nurse on the phone. Just listen to what they're saying and just realize that, there are other folks that may need that hospital bed. So I had a kid yesterday I had to send over to Reno, and I thought that kid needed to be admitted. Luckily, they didn't wind up needing admission. We just had to keep an eye on them in the emergency department. But the point is that there were so many people waiting in that emergency room, so much triage going on. I was actually seriously nervous that he wasn't going to get the care he needed. Okay, so we need to kind of think of the bigger picture here and just keep perspective and just know that, no, we're not sensing apocalypse here, right? But we are sensing a mess. And we really can't quantify the real risk here. And what I'd hate to do is for us to kind of wait until our ICUs are full to think about response, right? So what we've encouraged the healthcare folks to do is start thinking about collecting your data. Start understanding what your current capacity levels are, how many folks are admitted, how many healthcare workers are infected right now. You're going to need to track that. What's your ICU load look like? How many ventilators do you have? I mean, start getting to know your baselines really well so that you can communicate that to other healthcare facilities who may be able to help you if you get in trouble. Okay?
So one thing to note is we are videotaping. You can watch the video program. So one thing that else you can do is be emissaries in your own community with your own groups of people. To try and provide the kind of balanced information that Jim just gave you. So be a voice of reason, caution, but reason in your own communities. That's why we're here in the NSF, and we want to be able to empower you to do the same among your communities. So with that, Jim, thank you very much for a very insightful program.